Good morning, folks, and welcome to our Talking the Opioid Epidemic, Power of Data and Partnership. I'm Dr. Nathan Schlicker, and I'm joined by my co-host, Dr. Stephen Anderson, and we are excited to be sharing with you today as part of the Opioid Response Network's program. A few words from our sponsors before we dive into the content. This is a program that was designed by SAMHSA as part of the State Targeted Response Technical Assistance Grant that created ORN. And the program helps bring technical assistance to bring evidence-based prevention, treatment, and recovery of opioid use disorders to our communities. And we're grateful for their partnership in this effort. The ORN provides these local experienced consultants in prevention, treatment, and recovery to our communities and organizations to help address the opioid crisis that we all know hasn't gotten better in the middle of a pandemic. This effort, you're interested in joining it, you can find more at their information here, their website, phone number, as well as emails. And at the end of this presentation, we will have a Q&A session. So please feel free to hold your questions until then, and then we'll dive in. If you do put them in the chat, we will try to monitor them, but I can't guarantee that we'll see them all. With that introductory message, I'd like to turn it over to Dr. Stephen Anderson, my partner in crime here.
Thank you very much, Nathan. It's been a pleasure for the last 12 or 15 years to work on this with you. My name's Stephen Anderson. I'm a practicing emergency medicine physician for 35 years in South Seattle, Washington at Multicare Auburn Medical Center. Besides being chief of staff, past chair of the department there, I've been honored to be the Washington State chapter president of ACEP, as well as working on the national board of directors for ACEP, as well as being treasurer and chair of the board of that. I have no conflicts to report, and I'm honored to also have been a co-author with Nathan on the Washington State 7 Best Practices that you'll hear about this morning. Nathan, you want to tell us about you?
Gladly. I'm a practicing emergency physician in Tacoma, Washington, a little farther south than Seattle, and also serve as the Regional Director of Quality Assurance for Team Health and as the Associate Director of Litigation Support for our company. Like Steve, I've been a past president of Washington ACEP and currently serve as the president of the Washington State Medical Association, where I serve as the physician lead for the Better Prescribing, Better Treatment program that grew out of the ERS for Emergencies program Steve and I co-authored so many years ago, as he alluded to.
So we're going to start way back when, and we're going to talk today a little about the history of the war on bad policy, because there's bad policy today, but there was bad policy back in 2012 that kind of started Nathan and I on this trek. We'll talk about building partnerships, both with our state government that made a difference, as well as private industry when we talk a little bit about the emergency department information exchange, which was part of the key to our solution. And we're definitely going to talk about how data drives transformation, and that how by presenting the proper data in the proper form, you can actually make a difference in your convincing others to join you in this battle. Next. So bad budgets drive flawed policy. Back in 2009, the state of Washington started undergoing a financial crisis. And around 2011, they were in the hole and going to be $32,000 in debt. And the state decided that the way that they could get quick savings and resurrect the budget was to take it out of Medicaid spending. And they proposed the way to do this was to just not pay after 3 visits to the emergency department for anyone in the state of Washington on Medicaid. And they narrowed it down to a list of 700 diagnoses that would qualify. Ones like chest pain, shortness of breath, abdominal pain, sudden loss of vision, hemorrhage and miscarriage. You basically get the gist. This wasn't going to fly as far as emergency medicine was concerned. And so we were working also on a false stigma that unnecessary visits were basically opioid addicts, doctor shoppers, if you would. And that started the wrong approach, but there were other things that we had to battle too. The idea that emergency departments are filled with non-emergent visits that'd be better treated in a PCP's office. Well, the CDC back then said that only 4 to 8% of all visits to the emergency department were non-emergent visits. So at least 92% of the people needed to be there. And then the chief medical officer of Medicaid in Washington state printed on the front page of the Seattle Times the following quote: "Emergency physicians and hospitals have been abusing their privilege for years, billing the state for non-emergent care. They are poor stewards of the healthcare dollar." Well, this was a shot across the bow of Washington ACEP. And in reality, a level one Medicaid bill was only paying $12.28. There were no other doctors in the state of Washington that were fighting us in the emergency departments for these patients. Next. And so going back to those unnecessary visits, those ones that were all fueled by opioid addicts, this stigma was something we needed to pay attention to, because I think we all remember Oakey's graph, which basically showed that around the turn of the century, overdose death rate in the United States started to skyrocket exponentially. And we all had those patients that would show up with their bag of pills, 28 different bottles from 5 different prescribers. And what became real clear to us early on was that there was no coordination of care of these patients, and that's where we needed to focus. Next. So the epidemic of pain was also around 2010. We started to realize that the graph of overdose deaths in America was paralleled exactly by the number of prescriptions that doctors were writing in America for opiates. You see, we were part of the problem, and we needed to take ownership of this. There are lots of different statistics. One of the ones that I think was pretty eye-opening was that only 4% of the world's population lived in America, but we consumed 80% of the global opioid supply and 99% of the global hydrocodone supply. We were part of the problem. We were part of the vectors. Next. So going back to that war on flawed policy, Dr. Schlicker and I realized that we needed to fight this, and we'll refer to the healthcare authorities policy as the Death Star. And we fought it on multiple different directions. We went to our state legislature. We went to the National Congress and Senate and argued our point. They agreed that this didn't look quite right, but it happened to be in 2012 when this fight came to a head, an election year, and no one really wanted to dive into helping us. We went to CMS. CMS sent us a letter back that said that this was in violation of prudent layperson, but they also didn't want to get involved due to the election year. We went to patient advocates. We talked to the American Heart Association, American Stroke Association. They said that this policy was in direct violation of their mission statements. We went to the media. It seemed like Nathan and I were on the local news, either radio or TV, about every other week. We were on the front page of the Seattle Times. We were on page 2 of the New York Times. We were really fighting this battle every direction we could think of, and we weren't making much progress because for some reason we couldn't get through to the lay public that this wasn't just rich doctors fighting against the government. Finally, we decided that the only other option left was to sue. And we went to the state Supreme Court and we sued them that this policy was not a reasonable policy. And next, we won. Thank you, Dr. Schlicker. We won. And instead of, though, jumping up and down and cheering and saying, neener, 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 we beat you, we actually went back to the state of Washington and we said, look, you got this $32 million budget deficit. If you actually talk to us in emergency medicine, we think we've got ideas on how you could save money and actually get better care for patients and make doctors happy. But what you really need to do is direct it towards 7 ideas that we have. First and foremost was integrating an information exchange across all the emergency departments, so that we could identify who the at-risk patients were. We wanted education that we could give to our communities and give to those patients about how they might want to better coordinate their care. We talked about identifying a group of patients that required extra coordination. You can call them super utilizers, high utilizers. You can use derogatory terms like frequent flyers. Our state decided to call them patients requiring coordination because that's really what they were. And when we identified them, we tried to figure out if there was a care plan that we could assign to them so that when they went to any emergency department, they'd be getting essentially the same care for their problem. We tried to arrange for early follow-up so that we could identify their primary care providers, give them an update on the fact that their patient was back in the emergency department again, so that we could get them back in to be seen in a timely fashion. So not just that feedback, but also, and we're going to talk about this a lot today, feedback to the hospitals, to the emergency departments, and to the individual providers on how they were doing with their care directed at these patients. And we decided that we would create some guidelines around prescribing narcotics through the emergency department. And it turned out that our narcotic guidelines were eventually adopted by 20 plus states in their parameters on what we should and shouldn't be doing through the emergency department. Next. You know, really the key to this whole thing was Eddie. Eddie was a system, the Emergency Department Information Exchange, that was born originally in about 5 hospitals. Nathan's and mine were 2 of the first ones, where if you checked into an emergency department, your name was sent up to the cloud. And click, Nathan. And after it went to the cloud, literally within a minute, click, you'd get the Eddie alert back on your, originally it was a fax, but then it became an electronic track board highlight that basically said, this patient has a reason that you should understand about their exchange. And there may be other things in this. And the other part of this whole thing was then looping in case management. Case management, instead of being just discharge planning from your hospital, it actually became case management in the emergency department. Because in the words of Willie Sutton, why do you rob banks? Because that's where the money is. Where do you put case management to really impact the opioid epidemic and coordinating care for super utilizers? You put it in the emergency department. Next. Now, Eddie is now in about 41 states in one fashion or another around the country. Some states like Washington State, Oregon are completely linked both to the emergency departments and back to primary care offices. But what happens with an Eddie alert is that there are triggers that trigger it. And if it's triggered, an icon appears on your trackboard, you click on that, and you're going to come to a page that looks a little bit like the right side of the screen. It's going to tell you demographics. It's going to tell you that they actually have a primary care provider and who that is. Real important right at the top is a security alert. If anybody's ever been injured from this individual in an emergency department or a doctor's office, it's going to warn you that up front so you can take precautions. It'll tell you the number of visits in the state in the last 12 months, where those were, what the dates were. If there's a diagnosis that's most often encountered, it'll tell you that. This is a sickle cell patient. This is a COPD patient. It'll also tell you individualized care plans to share across all emergency departments. And literally, sickle cell is pretty much the poster child for all of this. Here's the medications in the following order, and if it doesn't work, you may have reached the point you need to admit someone. And then in 2015, we added to Eddie our prescription drug monitoring program, but instead of making it 3 clicks to crazy, or I heard in one state, 12 clicks to crazy, there were no screens you had to go through and passwords you had to log in. With triggers that we agreed with to the state, it was automatically pushed into Eddie. And this was a huge difference, basically because just like vital signs, it was now on your screen. But in addition, it took the entire bias out of the scenario. I was no longer just looking up my 22-year-old with 17 tattoos and 3 teeth. I was now understanding why the 32-year-old mother of 2 whose kids were playing on the floor in room 12, I was in the midst of a negotiation over Percocets that I couldn't understand. And it was brilliant in taking out the bias as well. Next. We put up posters in all the waiting rooms of the state of Washington and in every treatment room in the state of Washington when we went forward with this. And basically, the posters basically said that we were changing the rules because we were in the middle of an epidemic that was causing the greatest number of deaths in America at that point in time, that we were going by different rules, that we wanted to take care of patients better by these rules. Now, the first poster we made up, it was eventually morphed or adopted by 29 different states, but it was maybe a little harsh. It basically said, you know, if your dog ate your Percocet, I want to see the dog. And the Office of the Inspector General actually asked us to take the posters down and redo them. And we did, we redid them. They were a lot more patient friendly, and they are now approved for use. But basically, it was a way of telling people in the emergency department who gave you that line of, well, last time, or when I was at X hospital, and we could say, no, 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 in the state of Washington, we're all playing by the same rules now. Next. Because what we started to realize in our partnership with the government, who was at this time starting to give us data on these patients that were coming in, was that our goal as far as saving money was not to decrease the 51 visits a year patient. That patient can usually be satisfied with a recliner chair and a turkey sandwich. Those weren't our problem. The problem was recognizing those patients who were coming in 4 to 6 times a year and trying to prevent them from becoming the patients that had come in 11 to 15 times a year, and trying to decrease the number of recurrent tests that were being repeated, like repeat CAT scans, et cetera. Really what we realized was care coordination was going to be better for patients and better for us. These were complex care patients. They were patients that had diabetes, that had renal failure. We started to realize that case management really did make a difference, and that if you didn't address the social determinants of health, you probably weren't going to make any difference with these patients coming back. And I know nobody on this call is going to be surprised when I tell you that our initial round of statistics showed that 80% of the patients that fell into this group of 5 or more visits had a associated mental health diagnosis in their past, or a 45% percentage of substance use disorder. Next. Because we started to discover the whole definition of what a super utilizer was. I told you that our trigger for Eddie was 5 visits in the last year. And, you know, Nathan and I did a really in-depth, I think, paper, rock, scissors to come up with that number originally. But it actually panned out that a study out of New York showed that people with 4 or more visits in the emergency department in the last year had a 48 times greater likelihood of dying of a prescription drug overdose. These were the patients that we absolutely needed to have in the crosshairs that we were going to address. But a super utilizer is defined by a lot of things, mostly lack of access to other providers. That can be geography. There are differences in the rural setting with access than there are in the urban setting, but both of them have challenges. Simple logistics. What are the hours of your clinic that they're open to getting people in? Some people work 2 jobs. It makes it almost impossible. The simple economics of the situation. What's your insurance or lack of insurance? There are a lot of things in those categories that cause a super utilizer to have to only have access to an emergency department. But the real thing we began to realize was that these were poorly managed real disease. The list of diagnoses that were diseases that we managed but didn't cure. I don't have to see the broken leg back because that's going to heal probably. But diabetes, COPD, renal disease, you know the list. And the pain syndromes was one that was playing itself into this as well. I said sickle cell disease is sort of the poster children because it's a real disease. It has a lifespan of approximately 42 years of age. But but chronic recurrent headaches, chronic recurrent undifferentiated abdominal pain, chronic back pain. These things were things that helped create a superutilizer, and we needed to figure out how to stop the revolving door. Next. And so we realized that we were also running up against a challenge from our colleagues, particularly in emergency medicine, who felt frustrated with care coordination at ED discharge. We surveyed all our ED physicians, and most of them said that they were not resourced to manage underlying disease. It was easier to just slap a Band-Aid on the problem and kick them out the door, get their blood sugar back to normal, give them a couple albuterol treatments, and maybe they could be kicked out the door. Because a lot of them faced scarcity of resources when they kicked patients out of the door. They had the attitude that there really is nothing more I can do than the Band-Aid, and that revolving door is going to be open and they'll just come back. But we started to present both to the emergency, one back, not next yet, Nathan. What we also started to realize, though, was the prediction on, is this going to get better or worse? We started to realize that the number of primary care providers in America was not going to increase at the same rate as the number of patients that were going to be seeking care, both Medicare and Medicaid. And so we realized we had to get our partners into this conversation, not just in the emergency department, but across the entire board of medicine. Next. Because a really pivotal study that Dr. Maria Raven did out of San Francisco was really compelling in the fact that you're not responsible for this entire grid, but the gist of it basically says that people that came to the emergency department between that 4 and 15 visits where we were trying to decrease their frequency in the emergency department also went to their primary care providers more often. They had more obstetrics and gynecologic visits. They saw specialists like cardiologists, nephrologists more often. These were patients with real burdens of diseases, and we needed to figure out a way to do more than just the Band-Aid. Next. And so we came back to the fact that care coordination really was the fixture on the back end of this. We started to realize that medical respite, housing for the homeless was one of the most important things that we could try to figure out. Warm handoffs to the community-based management, particularly back to their primary care providers. But there also had to be places to get people back to for substance use disorder with rapid intake. And we needed to start their care in the emergency department, if you would, bupe to go on an opioid treatment plan. They needed to be alive, so naloxone at discharge. We needed to make sure that social workers were in the emergency department with case management as opposed to elsewhere in the hospital, and really trying to set up next day or as close as possible to next day appointments. In the words of the past president of ACEP, Dr. Alex Rosenau, and this is one of the most often quotes that I use in all my talks, is, we don't need a moat in front of our emergency departments. We need a back door at discharge that actually leads somewhere. Next. And so the state said, this all sounds good, but we need data. And that's where we're going to go to next. The data does help to sell your story. It turns out in the first year of doing the Washington State 7 best practices, we decreased those high utilizers visits to the emergency department by 10%. The bump you see during influenza season was expected, but overall, we dropped those high utilizers 10% visits in the emergency department. We dropped Medicaid visits across the board approximately 10% across the state in the first year. And those numbers continued to decrease. And the state said, that's all well and good, but remember the reason we came to you first of all, next, is that we've got a budget deficit that we need to address. It's $32 million. Well, it turns out when all the dollars were counted at the end of the year, we saved the state $33.6 million with our 7 best practices. We decreased opioid prescribing through the emergency department. We gave physicians the tools that they actually wanted. and we actually moved this forward. But that wasn't enough to stop in the year 2014. We needed a process that continued on. And I'm going to turn it over to Dr. Schlicker now to talk a little bit about the ongoing efforts.
Thank you, Dr. Anderson. Well, the reality is that this program existed and where it's gone because of partnership. And, Steve and I are here to share it with you, but it would not have been possible without the partnership of so many other groups, the Hospital Association, the Medical Association, which now I'm the president of so many years later, and many emergency physicians, some of whom are on our call with us, people like Dr. Hine and Gidanos and Dr. Miller from Washington, because it took a community wanting to tackle this problem. This wasn't a top-down solution that we could just push out. It needed to be a bottom-up groundswell to fix opioid prescribing in Washington. And so we recognized that we needed to bring data and education and get everybody on board. We needed partnership, not just in the emergency department, but outside of the walls of the ED. Because we do own some of this disease as ER providers, we fight back though at the idea that it starts all with us. Because we look at the data and say, hey, only 4% of the pills that are out on the street come from us. You're picking on the wrong group. Go talk to somebody else. And by the way, from 2010 to 2014, when we were doing this program, you could look at the data, and emergency medicine was the specialty that had the highest rate of reduction in prescribing, 9%. Why are you talking to us? We're doing our part. But the data also showed that when you looked at the volume of prescriptions, not the volume of pills, 39% of the prescriptions came from us. And that's where we realized there was an opportunity to expand our work, because while we prescribe such a small number, most primary care doctors will in one day write for more opioids than I write for in a year. The reality is I was touching more lives. I was seeing more patients and giving them a small amount. And while that seems insignificant in the grand scheme, it actually is quite significant because of data like this that's come out over and over again, that the longer your initial prescription, the higher risk you have of becoming tolerant or addicted at 1 or 3 years later. This graph shows on the x-axis the number of days of first opioid use and the probability of still being on them at 1 or 3 years on the red or the green line. And what is staggering to me is that if you look at 30 days, if you write a first prescription for opioid for 30 days, and I think of emergency medicine probably not doing that, but I can think of a lot of surgeons who do, at 1 year, over 25% of those people will still be on opioids. At 3 years, 15% will be. But what really became important was the initial part of this graph in that bottom left corner, which is that you see that when we're at 0 to 3 days, it's pretty flat. Some people will still be on them years later, but at 3 to 5 days, we start to pick up that curve. And that's why it became so important to go after, albeit our very small numbers of pills, the number of scripts we gave in that window, because our initial prescribing could impact whether or not they were on it years later. It was contributing to the problem. And we can also go to the problem of all the things that are living in people's medicine cabinets, which is what the data also showed. Because this idea of doctor shopping really was a great media piece, but it's not reality. Doctor shopping is the more than one doctor. That's 1.8% of the problem. And the PDMP helps us with this. The Prescription Drug Monitoring Program and EDDI helps us with this. But when you look at this data from SAMHSA, what you see is that most of this comes from friends and family and people's medicine cabinets. 75% friends or family, either given freely, bought, or taken. Another 20% are from, again, that single prescriber who's handing out a large number of pills. Very rarely are the multiple doctors or the corner street dealer the source of most opioids. And so when we looked at this problem, we said, okay, we're a small piece of the puzzle at the beginning, but we're at the beginning. And we know that what goes into people's homes may live in their medicine cabinet forever. And we can talk about the fact that the medicine cabinet is the worst place to put opiates, behind a private closed door where everybody knows to go look and rifle through your stuff. Not a great place. So, we've worked on that part of this epidemic as well, but we said, we really need to go after all of this initiation and all of these sources of the problem. And we need to work across the house of medicine to do that. This is data that really says this isn't just an ER issue. And this was data that was produced by Washington's Department of Health. And again, it's really busy, but here's the high level. These are opioid naive kids, 14 to 19 years old, opioid naive, have not had a prescription for opioids in the last 90 days. And this was the average number of pills that they received by specialty of prescriber. Now, obviously, Steve and I are quite proud that emergency medicine is the lowest number at 15 tablets within our 18 and 42 guidelines. But you'll see that it goes up quite significantly. And I think we can look at some of these and say, 48.9 for orthopedics. Yeah, they're big surgeries, but is that really the average number that we should have? Should the median number be 40? Should more than half of prescriptions for orthopedics in kids be for 40 or more pills? I know when I broke my arm and got it reset by the orthopod, I got a lovely bottle of Motrin out of the deal, despite having compound fractures in my ulna and radius, getting a lovely beer block to fix it. I survived. I'm still here. Would 10 Percocet make it better? Probably, but I also survived. And I think had the orthopod tried to give my nurse mother 50 Percocet or 40 Percocet, she probably would have smacked him upside the head. Because I think that's where we've gotten to it, is that we've got a lot of pills out there from a lot of places from acute care that, again, work on that first 3 days of the curve and then take off. Because I don't think any opiate naive 14 to 19-year-old is going to use 40 Percocet in 3 days. That's a couple weeks. So this told us we need to go bigger. And we needed to look at how we were going to change people's behavior. There are lots of ways to do it. Money is one way. Rewards are often in medicine. We can look at MIPS and other programs that try to incentivize us to do better care. And we can talk for a long time about whether or not that works. There's punishment. We're going to take money away from you. We're going to take other remunerations away from you. There's shame and punishment, pure embarrassment. We can go look at hospital compare ratings and do that kind of thing. We can use data, which, if done fairly, is useful. But we can also make the right choice, the easy choice. And those last 2 points are really where Steve and I think really realize the solutions from this came. Because the reality is we all have a misperception of where we are the problem or not. We all think we're above average drivers. 75% of Americans think they're above average drivers, which we know is statistically impossible. We're not quite as bad as 94% of professors who believe they're above average compared to their peers, or 32% of computer scientists who believe they are the top 5% of the intelligent people in this world. Well, we know that statistically that doesn't work. But people always say, well, it's not me, it's you. It's not St. Joe's, it's Multicare Auburn. Well, on that one, it's actually true. But, we said, let's bring real data. So our original 7 best practices, got Steve, really brought the data and said, okay, we're going to look at this at a system level. We're going to give you by hospital. And this is one of our real initial reports that looked at the rate of ED Medicaid prescribing per 1,000 Medicaid clients from July of 2013. I will tell you across the board, this data is better. But even then, it wasn't that bad. Less than 10 out of 1,000 Medicaid clients. And there was some variation, but it wasn't crazy. But we gave this data to everybody. And just by giving them system level data, we dropped opioid prescribing, as Steve mentioned, by 24%. But we realized that, that still allows the it's not me, it's you problem to exist. So I went to my group and I said, let's do it by individual. Let's give everybody an unblinded report that says, here's where you are compared to your peers. And then we'll look at it by hospital. And each of these lines are a different hospital in my health system. And what you saw was that after the 2013 work, where we had already dropped prescribing and were some of the lowest in the nation, we went further and we dropped our prescribing even more. And more importantly, you see that the lines got tighter, they got more homogeneous. We reduced variation so that people couldn't come in, as Steve said, and say, well, the last time I was here, Or when I went to see so-and-so down the street at the other shop, they did this for me. We were able to make a consistent practice of care. And we overcame that small in problem by not just having Medicaid clients, but by having all of them, all of the prescription we wrote in the health system. But the problem was it also really lacked external comparison. It was great. I could say what our 7 hospitals were doing, but it didn't impact what was going on down the street. It didn't change what was going on in primary care. So again, it solved our little corner of the world, but it didn't work on the whole spectrum. So we said, we really can take what we did in the ERs for emergencies at the system level, what we've done in ER after ER, not just mine, but Steve and elsewhere at the individual level, and we can merge these two and tackle the next piece of this. And that was really round 3, what became better prescribing, better treatment. And a wily policy analyst at the WSMA, Jeb Shepard, and I, as well as many others, said, we're going to take this work and we're going to form a partnership and we're going to do it the right way. Because this time, it was partly a budget crisis in 2017, but it was also just a bad policy crisis. The state was tired of the opioid epidemic, and they said, we're going to solve this problem once and for all. We're going to make it so onerous to write a prescription in Washington state that there will be no opioid epidemic. And we're going to do that by making sure that every prescription in Washington is prior authorized. And we pushed back. We said, well, who's going to prior authorize our prescriptions for the giant hand laceration on Turkey Day, Thanksgiving Thursday, with a 4-day holiday weekend coming up? Well, we'll figure that out later. So, again, this is just bad policy. We've done this. We did it right in the ERs for emergencies. We worked together and we brought you the solution, and we want to bring you the solution again. Because the reality is prior authorization is only going to make it harder for the people that are doing it the right way. The people who are thinking, I'm not the problem, but are, they're going to rubber stamp it through. They're going to have their MA do it. They're going to find a way to figure it out. We needed to bring data and solutions. And so we partnered again with the Hospital Association and the Medical Association. And we said, we're going to do universal guidelines. We're going to bring data and feedback that comes peer-to-peer this time, not healthcare authority down, but peer-to-peer. And we're going to encourage the use of a medication-assisted treatment. And by the way, we're going to do it for all specialties. And that's what we did. We said, okay, let's do guidelines that are fair, that are easy to follow. Pediatrics 3 days, adults 7 days for acute pain. We also know physicians are smart, that if you say 3 days and 7 days, they're going to say, oh, how many pills can I cram into 3 days? How many pills can I cram into 7 days? And we said, okay, we want a fair rule, but we need some structure that's going to allow data analysis. So we're going to say up to 6 pills per day. Seemed pretty generous. So that's 18 for kids and 42 for adults. Again, pretty generous. That most people would say, wow, most acute prescriptions don't need 42. And we said, yeah, they don't. But even some of the biggest surgeries don't need 42. You can go look at the Michigan Open guidelines. There are only like 2 surgeries on the list that exceed 40 tablets. Total knee and breast reduction surgery with lymph node dissection. So those 2 are it. Your total hip recommendations are 15 to 20. You get your gallbladder out, 10. So the point was we wanted guidelines that were fair to say, look, this is really the upper limit. We agree that you should probably do less than that, but we're going to draw a line. We're going to say this is what we recommend. But if you are a total knee, if you are a mastectomy with lymph node dissection that has guidelines that say you should go above it, we're going to make it really, really easy for you, because prior authorization doesn't do anything other than drive doctors nuts and probably deny care. We're going to do an automated exemption process. All you have to do is write the word exempt on the prescription. It's done. It goes through. They just type in a little code at the pharmacy called an EPA, flies on through. No calling, no hassles, no nothing. But it also meant that if you hadn't been paying attention when the guidelines came out, the first time one of your scripts went through, you got a call from the pharmacy that said, hey, you're above Medicaid guidelines. Is this an exempt prescription? And hopefully the conversation went something like, what guidelines? Oh, well, 18 for kids, 42 for adults is the limit. oh, okay, I'll remember that. And I know it worked because I started seeing some of my neurosurgeons have a default set to 42, which seemed like an odd number. Not the 40, but 42. So it worked, that people heard and got the message. But we also said, now we've got guidelines and we want data, but we want data that's fair. And so we took extreme caution to calculate a fair data set. We said, okay, acute prescribing is 90 days. Pill counts, not days, because again, sometimes it'll get written a little bit weird in the way that it's calculated out, may make it look like a 30-day prescription or a 2-day prescription inconsistently. And we're going to include liquid, so there's not a giant gaping hole here that people can just say, oh, well, I'll just give liquid pain meds, not pills, which was one of the problems in some of our initial data set that we did in the ERs for emergencies. But we also said we want to make sure that when we're giving data feedback, it's about the problem we want to solve. We're not trying to solve bad chronic prescribing here. So if you wrote for once every 6-month meds, we built into the data set a way to control that and kick that out. We also knew that patients weren't exact. Maybe they got once every 3 months pain meds from their primary care provider, but patients don't make sure that they get it in under 90 days. Their insurance may only let them at 90 days. So they might go at day 91 or day 92. So we said, okay, in the data set, we're going to actually run up to 105 days. So when you look at the data, it's actually 105 days, even though the guidelines say 90, because again, we wanted it to be as fair as possible to providers and not pull in bad chronic prescribing. We wanted to tackle acute actual prescribing. So by doing that, we really have built a pretty fair data set that we think when we give people data, it's reasonable. And so quarterly, we send out an opioid report that looks at the percentage of non-compliant scripts, again, percentage, because we know that some people work half time, some people have shared practices, some people don't write any opioids, some people do all the opioids for their group. And so if we just said total number of scripts, it wouldn't have been fair. So we said, let's look at the percentage that are non-compliant, recognizing that all of us may have some because of reasonable surgeries, chronic conditions, acute conditions that justify above that limit, and we'll compare. And in the beginning, when we started in 2018, we were able to enroll over 40 systems over the course of the year and get 20,000 prescribers on board. That we get a lovely little Excel graphic like this, and an email that had my signature and personal email on it. So I got all the feedback. It was fun. And we're able to really kick this thing off. We also, though, said we want to give systems the ability to compare and look across specialties. And so the CMOs would get a report like this that would say, hey, where are outliers? And does it make sense? You'll notice some of the spikes on this graph are in pain medicine. Well, okay, that seems reasonable. They're treating chronic pain patients. Again, the data is not perfect. They may have moved from outside the state. The first script that they get in Washington is going to be really high, and they're not going to have one in the prior 105 days to drive them up. So we wanted to be fair to them, and we want to make sure we got data that looks at that. But we can look at other places like ENT, where maybe we're a little bit higher in our non-compliance, or in our pediatric medicine where it's a little higher. So it gives our leadership the ability to look through that. And with all of this work, what we've been able to see is that consistently over the last 3 years, we've seen drops in the percentage of non-compliant or high above guideline prescribing. And the data point that's missing before this is 2017 Q4, when we implemented those guidelines, dropped like a rock. So it would have made the access look really funny. So we've kept it to this, but we've made that consistent progress and really going after, I think, some of the most important work, which is the pediatric rate, because we know that young brains are still developing and are potentially subject to addiction up to the age of 25. So really seeing that rate drop, gives me great hope that we're going to tackle this moving forward. But we also know that we can work on this, and I always say there's 3 phases of addiction and of pain medicine, which is there's the acute phase where we get you started, there's the chronic phase where you maintain, and then there's the addiction and behavior phase that needs treatment. And we have been working on the acute phase in Washington for the last decade quite aggressively. We are starting MAT and Bupe to go, as Dr. Anderson alluded to earlier, on the treatment side. The middle section is where we've got, I think, some work left to do. We have pretty stringent guidelines in Washington, but we don't have a lot of data for prescribers. So we're working on chronic prescribing reports right now that will hopefully be coming out in the new year. And also, I think critically importantly, working on co-prescribing reports, because again, having Eddie, you can see the PDMP on so many patients that are getting co-prescribing of benzos and opiates or other sedatives and opioids that sometimes raise my eyebrow quite concerningly. We're also seeing encouraging growth. I mentioned 40 systems when we started. We're at 59 now and well over 20,000 prescribers. And we're also looking at other licenses. Dentists we have a small subset that are parts of large health systems, but for the most part, the dental community is not involved, but they do prescribe a number of pediatric prescriptions in particular that can create serious addiction issues. Who knows, maybe we'll get the vets too, because believe it or not, Fluffy the cat's prescriptions show up in the PDMP, but we're not quite there yet. So lots of future growth to continue to expand the feedback and the data. One other thing that we've been working on that I think is important using the power of data, our old partners, Eddie, have been really cutting some pretty cool new territory. Steve mentioned that we're integrated not only on the ER side, but on the primary care side in Washington. What they've been able to do is that when a patient comes into the ER for an opioid overdose event, and they see that there's a primary care provider in Eddie, they can real-time notify back to that provider that their patient has experienced an overdose event to try to close the loop so that we're not just having an isolated ER event, taking care of the acute problem, giving them Narcan, sending them home with Narcan, but actually going back to the issue so that the primary care provider can hopefully work on that and that connection is made and ensured. So that's the goal of that program, and we think will be very powerful moving forward. So in the end, I hope that Steve and I have impressed upon you that partnership really is required, not just between groups or specialties, but between organizations, businesses, and most importantly, with our governmental partners. We would not have been able to do either of these programs without the Healthcare Authority and Department of Health being willing to work with us, and now being willing to share their data. Good data helps us make informed change. Without that partnership, no data, hard to make change. I won't say no change, but hard to make change. And we need providers to lead this improvement. One of the things that we've worked very hard on is that this comes from the Medical Association and ACEP and the Hospital Association, and in finer print, Department of Health and Healthcare Authority. This can't be a punishment-driven solution. It has to be an education, data, inspiration-driven solution. And we want to make sure that making the right choice is the easy choice. We want people to know that if they are the outlier today, they can say, you know what? I feel confident because everybody else is practicing this way. I won't be alone. So we are excited and proud of the work we've done to bring partnership and data to the forefront here in Washington, and excited to take your questions. And with that, I'll turn it over to our moderators to kick us off.
So Nathan, I can already see some, both under the chat section as well as in the Q&A section, questions coming in. A lot of them are about how we track data now. And so real quickly, I'll say that there are systems that are tracking it, as well as our state Medicaid program, as well as collaborations we have with insurance groups as well. From a lot of different directions, we're trying to pool this data as best we can. I see some specific questions, and I don't know if you can see those, Nathan, behind all of your birthday presents, because before we end this, I do have to say happy birthday, Nathan. And thanks for taking some time out of your birthday to do this. One of the questions, maybe Nathan, you've got an idea. I can speak within my system on the percentage of patients who really have a significant opiate use disorder, who are actually willing to take or are getting Bupe out of my emergency department. I would tell you that 2.5 years ago, that was 0. I would have to tell you now that not all my providers have X waivers. but I would tell you that more than 50% of my providers have it now. There are some systems like University of Washington where it's 100% of their providers have X waivers. But we pretty much offer, in my system at least, 100% of individuals who are interested in starting their BUP in the emergency department can get it under the proviso. And we have a system we've built with our community clinics in town for early follow-up. I'm not sure I can give you an exact percentage, but I know it's a system that didn't exist 2.5 years ago and is taking advantage of every day in my emergency department now. Nathan, you're in Tacoma. What's your experience?
Yeah, no, exactly. I think it's interesting that our opioid epidemic experience has changed dramatically with, I think it was a better informed population that's suffering from addiction, more access to Narcan. Back when I started as a young emergency physician, it was every day we saw somebody with an opioid overdose event. And we're not seeing that as much anymore. We are definitely seeing the complications, abscesses, et cetera, still, but it's been a definite change. So the number that have wanted to partake of buprenorphine has changed with that. That said, we do use, and I think it's worth expounding on a little bit, as Steve mentioned, the X waiver. There is a 72-hour proviso in the law. You do not need a waiver as a physician to give a dose of buprenorphine in your emergency department. You can do it tomorrow. Tomorrow, you can give a dose of buprenorphine. So when somebody suffering from addiction comes in and they want help, and you don't have a treatment bed open because, let's be honest, resources are terrible in this country for getting people into real-time access, you can say, great, let's make the decision now to do the right thing, give them a dose of buprenorphine. You can do that actually up to 3 days in a row, over 72 hours. That's why it's called the 72-hour rule. You just can't send them home with it without an X waiver, as Steve alluded to. So we do that in our ER. We give them a dose of buprenorphine. And then, like Steve said, we've got connections that at 9 a.m. the next day, they can go in and get started on MAT in one of our community clinics. The challenge that I have is that because this is so new, that most of those people suffering from addiction know that they might have a prolonged stay in the ER. So what do they do before they come in? So they don't go into withdrawals in the lobby and leave AMA. They dose up before they come to us. And you generally don't want to start buprenorphine within 8 to 12 hours of your last use. And some of them have been on bup before and know that they've thrown themselves into withdrawals. So I think it's also educating the community that this is a resource that's out there, so that if they want to, they don't just dose before they come to the ER, because unfortunately then I can't give them buprenorphine. But I offer it probably every shift, if not every shift, every other shift. But how many I can actually get to take it who haven't dosed is a different problem, unfortunately.
So I will just go on to jump to the next question has COVID changed any of this? And I'm going to tell you, in my particular community, absolutely. I actually am now seeing a bump again in overdoses because I'm seeing a huge increase in anxiety, depression due to social isolation, which is different than social distancing in my department. I can tell you one of the key things to do in the department as far as BUP goes that we found was getting people over the stigma of addiction and opiate use disorder. And, you know, the statement I make to all my colleagues and when I lecture is, I don't label my COPDers as albuterol seekers. I don't call my DKA patients insulin seekers. I don't call my patients who have opiate use disorder drug seekers. I treat it as a disease process, and I now have a drug that can definitely, no question from data, decrease their risk of death and change their trajectories. And if I put it to people that way, all my providers in my department now have bought into it. I'm just trying to see some of the other questions that are popping up is the rise of methamphetamines. You know, there's studies that are coming out all over the country and they're small, but we have to start paying attention to them. Is there a naloxone or a buprenorphine equivalent for methamphetamines? There are places researching gabapentin and other things along those lines. I would clearly tell you that some of the statistics that you're seeing from Nathan right now on our continued decrease in prescribing process is also an uptick in ALTO programs. ALTO programs, alternatives to opiates, as far as regional blocks in the department, use of topicals, use of gabapentin and other medications has also increased across the board. And that makes a difference to us as well. The bigger the toolbox, the better, in my opinion. And in my opinion, starting at the right side of the toolbox and working to the left, which is start with Tylenol, start with ibuprofen, start with lidoderm patches, and move your way across to the right side of the toolbox, which is the opiates and surgery, as opposed to the way I was trained literally 35 years ago was opiates work, just reach to the right side of the toolbox. I think it's a mindset that we have to give people.
Definitely. And the next question, I see it, about the methamphetamines. I think, DOH actually has some interesting data coming out showing that as we've started to curtail the deaths from opioids, the deaths from methamphetamines are starting to rise. So I think in 10 years, we'll be talking about the next great epidemic. The question again, did medicine fuel some of this rise with, the number of kids we've started on Adderall and other synthetic amphetamines? I think will be the next great conversation. We're not there yet, but it is being discussed. Other one, do we give bup or Suboxone, basically bup plus naloxone? Buprenorphine is way cheaper than Suboxone, the trade name. So at least in our department, we are giving buprenorphine because we're dispensing it. They take it in front of us. So there's not really a risk of abuse or diversion. So it's much cheaper for that reason. But I think most of our treatment programs in the community are still doing combo therapy or Suboxone.
So I'm going to tell Amanda, I noticed the next question talks about bup protocols, microdosing. You already suggested, Nathan, the challenge of not putting people into acute withdrawal by using it. But I will tell you that there is a pain management and addiction medicine section in ACEP. And if you are interested in all the research that's going on alternatives to opiates, on how to microdose and use different protocols for bup, how to use bup in the acute withdrawal elicited by naloxone. There's lots of real cool data that's coming out and being discussed in that forum. And I tell you, it's a great section to join in ACEP if you really want to know how you're going to practice pain management in the next decade. We don't use microdosing protocols, but I can tell you that I know that Eric Ketchum and some of the real experts in this field are looking into all of these. I mean, I was fascinated at ACEP 2020 to listen to their section discussion on injectable gabapentin and all sorts of other things that they're looking at. I can just tell you that the research out there is fabulous, but to jump to the next question, at your hospital, it involves conversations that involve not just the emergency department, but pharmacy. You need to get your CMO on board. You need to get, it's a team effort, as Nathan said, starts locally in your hospital, moves out into your community with your other providers. And if you're lucky enough to have made a $33 million difference to your state budget, you can actually walk in the doors of your state government and influence legislation as well, because advocacy really does work, particularly when you walk in the door talking about trying to fight the outcomes of COVID or the opiate epidemic.
Definitely. And I think one of the key things that when you have those conversations that we ran into is that sometimes it won't be set out publicly, but sometimes you'll hear from CMOs or other leaders, well, we don't want these patients in our emergency departments. And if we do this kind of a program, we'll recruit them to our departments. And the reality is you won't. This is another tool in the toolbox. And again, if all of us are doing it, we're not going to be upping the undesirable quotient. Instead, we're going to be getting them help. And they're not going to be the frequent flyers that do come in over and over again. They're going to be the people requiring care and coordination that we're actually going to be treating. We're going to be getting them care. We're going to be getting them into long-term therapy. And so this isn't going to affect their perception in the community, their stigma, et cetera. This is actually be treating their community. So you may run into some of those less political conversations behind closed doors, and know that we've tested this over and over again, and it hasn't gone the way of the greatest fears. It's instead made a difference in the lives of our patients.
But working with your state and even your county makes a huge difference. There's a big dump of money that's come in the last year from the federal government. And I don't know if it's happened yet in Pierce County, which is where Nathan works, but in King County now, there's actually a website you can go to that says, what's the closest BUP follow-up center to your emergency department that's accepting patients tomorrow? And I could actually go on that website and say, here's the address of the closest place, walk in here tomorrow. Although we have a little bit better grease system even than that right now. But having your regional government have a website that says, where can I go for BUP, is a step forward that can make a difference as well.
Definitely. And what Steve said, I think, there was a push legislatively 3 years ago, I think it was, that said, well, the ERs should all be mandated to be X-waivered and all should be willing to prescribe a week of BUP. And again, we don't need a moat. We need a backdoor that goes somewhere. We pushed back on the state government and said, no, just cycling these people through the ER every week to get their buprenorphine is not a solution. We need resources in the community. And we pushed back on them and actually got a lot of support and got clinics built. And we said, if you build it, we will send them. We promise. And we've been able to help build that connection. But sometimes it takes working, again, collaboratively with the government to get rid of bad policy that may be well-intentioned, but isn't actually the solution that we need. Did we lose Steve?
We lost you for a second, and then we lost me because we lost everything for a second. But I think we're back, Nathan.
Well, maybe that's the universe saying that we've run up against our 10 o'clock time frame, my friend. Any closing comments or thoughts that you want to share with our audience here?
Well, I would say that with COVID, this hasn't gone away. If anything, substance use disorder and opiate use disorder has, at least in my shop, maybe even come back up with a roaring head because of depression and anxiety. I would say that getting rid of the stigma is one of the top things you can do, both in your department and in your community. Working with other organizations is part of the solution. And ultimately, you can change behavior by economically incentivizing it, peer embarrassment, but data helps, and making the right choice, the easy choice, is what I try to push for.
Well said. Partnership, data, and I think compassion. This crisis has brought forth that many people are suffering, and unfortunately that suffering and isolation and depression and anxiety drives a lot of substance use to cope in maybe less ideal ways, and we need to be compassionate and non-judgmental. And if we can do that, hopefully we can intervene on just more than their acute crisis with a Band-Aid, but make a long-term difference in their health. So
hey, Nathan, Nathan, the last thing to leave people with is that this will be archived ultimately, along with, this is a series of, I believe, 6 different seminars at the ASAP website. So drive your colleagues possibly to one of these to listen and come up with solutions at your local level.
Great closing words. Well, thank you all for joining us today. We appreciate your time, and we wish you the best of luck at tackling the opioid epidemic in your community. We'll catch you next time.